Welcome to the iDryNeedle to the Point podcast. Today we welcome physical therapist and dry needling skeptic, Dr. Jared Hall. Welcome everybody back to iDryNeedle to the Point podcast. If you've never joined us before, I'm your host, Paul Kaloran. I'm a physical therapist, dry needling educator. I'm the founder and president of iDryNeedle. And honestly, because I think this guest and this topic is probably going to bring an audience that might not have otherwise been here. Hopefully that little introduction of myself gives away my bias. I've been dry needling for almost a decade now. I teach it. I have a product company. I mean, it's what I do. It's what I talk about. It's what I teach. And I think that's valuable because, again, this is going to be a very different podcast than what we've had in the past. Every guest we've had so far is excellent. They're educators, they're researchers, they're industry or topic experts in dry needling. Our guest today is also an expert, but he's on the other side of that. We're not on today to just talk about uniform, just agreed support of dry needling. We're going to talk about the debate, the disagreement on dry needling. Not every PT loves needling. And honestly, I try not to get involved in the social media back and forth. Part of why I try not to get involved is a lot of the strongest voices out there don't have the training. They've never done needling. They look at it from an outsider view as kind of the fad, the modality. They see the hype. I think our guest today is perfect because he is trained in needling. He actually says he has utilized it heavily throughout different phases of his career. And he's still here to kind of challenge the ideology, the methodology of dry needling. So with that topic in mind, I do want to introduce, very happy to have Dr. Jared Hall on the call or on the show today. He is a PT, DPT. He has his OCS and his CSCS. Aside from what he does clinically, he's actually the co-owner of Modern Pain Care. He's a lead instructor with the Optum Manual Therapy Fellowship, the OCS prep stuff. He's also written books. I mean, he's squarely in the pain science, therapeutic neuroscience education realm. He's co-author of Making Sense of Pain and Wrinkles on the Inside. And he's also an adjunct faculty at University of North Texas, which is actually where we met. I don't even know what year it was, long time ago. It was early on when I had first begun teaching dry needling. UNT hosted a needling course. I think at that point you had been through other courses, so you kind of just dropped in to say hi and see how things were. But I've actually met him once. Aside from that, it's just, we've had this back and forth, this continued friction on social media. But what I do appreciate is that even though we are, when we get down to the topic of dry needling, we couldn't be on further ends of the spectrum. I do appreciate that Jared and I have kind of landed in this mutual respect, this professional agree to disagree. I guess that's where we landed. And that's what we're here to talk about. So Jared, thank you for being on. Is there anything I missed? Anything you want to say to the audience?
No, man, that's quite enough about me. And I was thinking back on it. I think, I don't remember if it was 2012 or 2013. I know that the University of North Texas Health and Science Center is kind of like a hub for Kineticore to teach a lot of courses out of. And I was in school there from 2011 to 2014. And, I'm one of those dudes that's just like absolutely almost addicted to learning and like taking as many courses as I can and that sort of thing. And when I was a student, I just volunteered. I was like, hey, look, I'll pass out lunches. I'll clean everything up. I'll vacuum the floors. I'll wash the windows, like whatever you guys want me to do. Let me take these courses that you host here. And that's actually how, when I was a student, I ended up going through DN level 1 with Kineticore, I guess 3 times. The first time was as an observer. The second time, actually, I believe I was allowed to participate quite a bit. And then the third time, I think I just popped in and out just to see how the course had updated.
Yeah, exactly. That must have been the time I met you. But yeah, I like that exposure. And as we dive in, again, we're going to get into some of the finer details of, I guess, the foundational theories of needling and even clinical benefit. So before we get into everything we disagree on, I thought it'd be valuable for the audience to say what we agree on. And I'm basing this off of mainly the podcasts I've heard from you, the blogs and other commentary. So first of all, I'm going to say what we agree on is that the trigger point model, the trigger point theory, is incomplete. It's inaccurate depending on how far you take it. It's an antiquated explanation of pain pathomechanism and even somatic referred pain as being a generating tissue for pain syndromes. And therefore, I think it's kind of an inadequate explanation to the therapeutic benefit of needling. So I'm sure we're going to touch on some of those nuances, but I'm just going to say here, I agree. Like if we start talking about reliability of trigger points, and if that is an accurate model to why pain exists and why needling works, then I agree with you. I also agree that if dry needling is put in a vacuum, dry needling in isolation only provides short-term benefit. I 100% believe with many of the other passive modalities and interventions and techniques we do in the clinic, if you are just dry needling, there is always going to be short-term change, whether it's pain, whether it's function. And I teach that on the course. I mean, just to exaggerate the impact, I say 90% of your outcomes for needling is what you do after the needle. And that's either corrective exercise, that's lifestyle modification, or that's identifying what is causing this painful syndrome that led you to put a needle in that muscle. I also believe, even non-needling, that pain science, that therapeutic neuroscience education needs to be a bigger part of most clinicians' practice. I think it should be a bigger exposure in PT school, in the DPT program. But whether you are heavily an interventionalist using needling, manual therapy, anything else, if you don't have that foundational knowledge, if you don't know how to reframe that narrative of pain in your patient's brain and in their life, most of your interventions are going to fall short in research and in clinical practice. So with everything, and is that fair to say, I guess, that we agree on those general topics?
Yeah, I would say that's pretty good summary of definitely points where we could get on board with each other.
Where we disagree is everywhere else. And again, this is really just based off of commentary I've seen on social media. One is that acupuncture and dry needling are essentially the same when you look at the neurophysiology and the intent. Two is that I disagree strongly that the primary effect of needling is just this theatrical meaning response that we either intentionally or unintentionally infuse our bias into. And it's that strong of a belief system for us that we press it upon patients. And that's really where we're going to get started. I did want to paint the picture, and you actually already kind of did it for me, but you do have training and experience clinically with needling. You kind of went into how you first got trained. But yeah, painting the picture for the audience, what was your first exposure to needling? And then when you said you used it heavily clinically, just what has your experience been throughout your career, the journey of your career using needling?
Yeah, those are really good questions, man. My first exposure was when I was a student. And in Texas, the laws actually allow you to dry needle the second you step out of school, right? You don't actually have to be quote unquote certified, but it's strongly encouraged, obviously, for legal reasons and all that sort of stuff. And obviously, nobody should ever do any sort of treatment, especially one that's invasive, without some training and understanding of the safety and the contraindications and so on and so forth. So that was my first exposure. One of my professors in PT school, who was my mentor, really the guy that I looked up to a ton. He was a big proponent of dry needling, and he actually taught with Kineticore for a while. When my mentor was super big into the concept, I definitely wanted to dive in head first. When I graduated, the rules had kind of changed. Kineticore would no longer teach to people unless they had a year of clinical experience. They kind of shifted that like right before I graduated. So I decided to take some other courses. So I took what ended up, due to a personal issue, only ended up being half of a myopain seminars course. And then I've also taken the Dry Needling Institute with James Dunning, his DN1 and DN2 courses. So to get some different flavors. And then one of the guys that I practiced with for quite a while was trained with the Gunn radiculopathic model. So Dr. Gunn's approach. So I would say probably, like 4 different concepts of dry needling, or different education institutes that I've been exposed to, but my primary education has been through Kineticore and the Dry Needling Institute with James Dunning.
Yeah, and I actually like that. I mean, I teach for Connecticut, which is actually now EIM, merged a few years ago. And I think that's valuable because I also have taken some of the other US institutions, US dry needling education. And that's worth acknowledging, even if you right now are a dry needling clinician. I guess the methodology, how you explain the treatment, and even how you use the needle is substantially different. There are still models out there that do heavily rely on the trigger point model and Janet Travell's work. There's kind of the other end of the spectrum where you almost deny that that is a realistic, feasible explanation of what we're doing, and it's more about neurologic input or even like homeostatic autonomic nervous system responses. So I think that's valuable, and yeah, I'd say you actually have more dry needling specific training than probably most dry needling clinicians out there. And that kind of makes me curious. Again, I've heard on podcasts and stuff, like there was kind of a stage in your career where you heavily used needling. I mean, you said thousands of patients, you needled almost everyone that came through the door. So before we get into kind of some of the challenges, I'm kind of curious, at that point in your career, how did you explain the benefit of needling to a patient when you were preparing to use it in their plan of care?
You know, man, to be honest, it's really easy to think back 6 or 7 years ago and probably tell myself that I said something than what I did. But if I'm being honest, you know, right when I came out of school, I was 100% on board with the trigger point model because, as you probably know, that was the primary model that was being taught with myopain seminars, but also when I took the original Connecticut courses, it was heavily, influenced by that group as well, and there was a lot of the trigger point hypothesis. So I was palpating, I was needling the heck out of every trigger point that I could find. And then, you know, I started taking some of James Dunning courses, and I started to think, well, you know, he proposes a really valid critique and counter argument to the trigger point hypothesis, and that got me reading down a rabbit hole. And I decided that, you know, after some of the stuff that Dunning presented, and then finding, you know, John Quintner and Milton Cohen and reading some of their critiques of the trigger point hypothesis and the myofascial pain syndrome concepts, that wasn't something that I could hang my hat on. But at that point, I still continued to dry needle, and it was more through the lens of, you know, this nebulous neurophysiologic effects, right? Because there is no denying that a lot of times when especially if patients are seeking it, they've been referred to you for it, they have a positive expectation for dry needling, you see a short-term positive response with dry needling. There's no denying that. And I don't think that anybody could make a valid argument against the fact that you could see some short-term changes. So that's kind of the window of opportunity mindset is what I developed towards. But then as I started learning a little bit more, started learning some things from Adrian Lowe, started learning some things from Fabrizio Benedetti, started learning some things even more maybe from Lorimer Mosley and Mark Karjla, Jason Silvernail, you know, Greg Layman's, Ben Cormack's, all these people that are, you know, intelligent, Sandy Hilton's and stuff like that, intelligent people that gave me a little bit more nuance about the clinical interaction. I learned a lot about the placebo effect from Fabrizio Benedetti. I learned a lot about neurophysiology from some of those other people about concepts like conditioned pain modulation, or, you know, the diffuse noxious inhibitory control. Learned about gating at the periaqueductal gray matter, things about the rostroventral medial medullae in the brain and how they affect incoming, you know, sensory inputs. And I started to change my concept of what I thought was occurring with dry needling. And I think that part of that is a sensory stimulus that is put into the system with a needle, which is it's a very aggressive sensory stimulus, probably more aggressive than, you know, just about any other form of manual therapy. And oftentimes it is uncomfortable, especially if you do like a twisting technique, or if you do a sparrow pecking technique, or, you know, pistoning or whatever it is, or if you put in some pretty strong electrical stimulation along with that. There's a lot of stuff going on right there, and I think that you could definitely elicit some diffuse noxious inhibitory control, or that counter irritation mechanism, and probably release some endogenous opioids in the short term. You could probably cause some interneuron gating in the dorsal horn of the spinal cord, you know, all the way up. We could talk through the neurophysiology, and as I started learning neurophysiology, my concept of dry needling and what was going on, both from the theatric standpoint and from the neurophys standpoint, started to update over time. And I'm still updating that to this day. And it's been, almost 9 years now, and I don't know the right answer. I just know that I've changed my concepts about what I think is going on in that interpersonal interaction and with the stimulus of the needle over time.
Yeah, and what's interesting is I won't tell my whole story. I was skeptical of needling. I was exposed to it as a student, and you're standing in the corner of the treatment room, whatever, 3 or 4 needles go in, patient touches their toes for the first time in 5 years, pain drops in half, straight leg raise improves. And this was as a student, 2008, where we didn't even have like the mainstream, like public recognition of needling. So it's interesting to hear your story, because I entered dry needling very skeptically. I also entered dry needling, like you mentioned, when Kineticore relied at least partially on Janet Travell's the trigger point model. We didn't have eStim, the twitch response was valuable. And I guess just for those of you out there that might not have that trigger point heavy training, and without giving a full lecture, like it's based heavily on the energy crisis model in tissue. Some strain or injury on the muscle causes this inflammatory and biochemical cascade. We get this accumulation, which impacts function, but really oxygenation and health and nutrition of a muscle. Even Janet Travell eventually kind of modified that energy crisis trigger point model, calling it the integrated hypothesis, saying at some point that accumulation histologically in tissue irritates, sensitizes the adjacent peripheral nervous system apparatus. That's where you start hearing terms like the neurogenic inflammation and making it sound more nervous system. But really, even that explanation stopped, I guess, as high as it went is the dorsal horn and that segmental level. And then that's, I guess, where I disagree, because I do a lot of research and diving deeper into the more research coming out each year, diving deeper into the neurophysiology. I am fully prepared in 5 years to teach at least the therapeutic benefit and the foundational rationale of needling, completely different than how we're doing it right now. And I see it as cortical. I mean, what we're learning about what happens somatosensory input, like at the cortex, and really what we know in the context of not even chronic pain, but the pain changes, somatosensory reorganization, how that impacts pain as an output, but even motor patterns and all of that. I think what we're going to be saying, even if the technique, when it gets down to putting a needle in that vastus lateralis, will be exactly the same, our explanation of the change will be less local, less biochemical, less histological, and not even neuromuscular function at the lower motor neuron level. It's going to be cortical impact. And that's where I guess I'm seeing that every clinician, every treatment will have bias. And maybe we'll go into kind of your thoughts on that being like the cost investment contributes to how heavily dry needling clinicians promote dry needling. And that happens with any treatment. But I think what we're seeing, big picture, central nervous system input from needling, it's powerful, and it's not just a placebo. So it's funny because we kind of started on the same road, but yeah, we're going very different paths from there. But I like the context you're giving it. So we've mentioned the trigger point theory, and I guess I'll jump onto that question next, because most of the contention I've heard from you personally, but also just from those larger voices, mainly on social media in our profession, that challenge, and challenge is putting it nicely, because a lot of times it's pure stigmatization, factionalizing, and even mocking dry needling clinicians for using it based on the trigger point theory. So I guess I have to ask, because it seems like your thought, your training, and your personal research has taken you beyond the trigger point theory. What do you say to those clinicians sitting here that don't fully subscribe to the trigger point model? Like, it almost seems like we're throwing the baby out with the bathwater if we say there's this flawed trigger point theory, therefore dry needling is bogus, it's biased, it's placebo, because this foundational theory doesn't fit. What if they're saying that's not the foundational theory that they subscribe to, that they make sense to, and it's not even the narrative that they give their patients as far as benefit of needling? Yep.
Yeah. So no, that's a really good question. And, as you already alluded to early on, my feelings on dry needling started changing because of my education on the trigger point hypothesis. But that's I've moved on quite a ways away from that in and of itself. And to answer your question, the underpinnings of the trigger point hypothesis and the model kind of being torn down or disproven by certain research studies and that sort of stuff, that's one thing. And there's a lot of different treatments that address trigger points, whether it's ischemic compression, or whether it's active release, or whether it's dry needling, or whether it's some sort of gua sha or instrument assisted soft tissue mobilization type stuff. The trigger point hypothesis has been used as a explanatory factor for a lot of different manual therapy techniques. But I don't want to use that as the only reason that I have a difference of opinion to the dry needling crowd for dry needling. And the real reason that I still, even though we've talked about a lot of these neurophysiologic processes, and you alluded to cortical factors with reorganization and all that sort of stuff, which is definitely interesting. My stance on it is that when I see the really well-controlled research studies done where there's actually some sort of sham, and it seems like the assessor is blinded pretty well, or the study does what it can to blind a patient, which I think is really hard, because if you've been needled, you know that getting needled feels different than getting poked, right? A lot of the time. So I'm not sure that we can ever create a true sham with needling, but there are, toothpick models, there are retractable needle plunger models. And when I see those studies come out, the effect sizes are really, really tiny when you compare active dry needling to sham dry needling. So, we'll say with a control group over time, they reduce 20% pain. And with the active dry needling, they reduce 40% pain. And with the sham dry needling, they reduce 35% pain, right? So it's like, to me, that difference between sham and active needling doesn't often meet clinical significance. Almost never. I'm not sure if it really has ever, in a well-controlled study, met clinical significance. It doesn't often meet statistical significance, and that's factoring in the problems that we can have with clinical equipoise, the problems that we can have with not having an adequate sham or blinding the patient 100%, and not controlling for the contextual effects that can influence placebo effect and that sort of stuff. And then finally, not controlling for patient expectations of people who are either on board with and open to the concept of needling, have heard about needling, or have had needling in the past, or been, quote unquote, sold needling. And I don't want this, I know that this is a dry needling podcast, but I don't want to use that explanation to attack dry needling. I think that that's a lot of the stuff that we do. That's pain neuroscience education. That's core stability for low back pain. That's manipulation for cervical spine, right? I think that I'm obviously a skeptical person at heart, and I think that I've just become a lot more difficult to buy into something hardcore until I see a little bit more definitive evidence, and especially when the stronger evidence that I see isn't necessarily showing a strong statistical or clinical effect. So I know that was a mouthful, and I know that was a lot of things to say, but I was just flowing with the thought process.
Hey man, that's why I brought you on. So first of all, to respond, you said dry needling, the toothpick sham research was actually acupuncture. So first of all, just to make the comment, does acupuncture research count or not? Maybe is the answer. You really have to look at the methodology. How deep did they go? What was their intent? All of that. But yeah, there is acupuncture research out there. Group A got a sham, which was the toothpick or even just guide tube pressure to the skin. And group B got actual acupuncture. And there is research saying that there was no difference. We do have sham controlled dry needling research, which I agree with you. That's an interesting one to try and control. It's funny because Louis Pontedera, who used to be at UNLV, now he's at Baylor, did this low back pain patients, needling versus sham needling, lumbar multifidus. They did see a significant improvement in contractile thickness, not even just of multifidus, but of transverse abdominis. But a secondary finding was, like you said, if they had needling before, consistently, high percentage of them could say that there was a needle or not. If they hadn't, they weren't able to consistently say. So I believe you, and I agree with you that the patient experience, a needle naive patient that's never felt a needle, you lay them prone, put a guide tube, a toothpick on their back and say, was that needling? They might not be able to tell. And you pointed out some of the acupuncture research where maybe that feeds into like their pain decrease because they thought they had a needle in them. I guess if you're cherry picking research there, I'll cherry pick and say that, yeah, we do see changes in muscle function. There was statistically significant changes in low back pain, sham needling versus needling. So there's mixed research out there. I think we have to be careful when we say that sham needling study didn't show any difference from actual needling, because that is kind of blending some of the acupuncture research. But I do get the point of, if we're just saying, is that patient experience without a needle, the sham experience feeding into a placebo change? I think definitely. And that brings us into the next one. I mean, just to pull directly, I mean, again, I try not to get involved, but I have gotten involved in a few of the conversations. To start with the first one, well, let's jump, because we just talked about acupuncture. One of the most inflammatory, the instigatory that I've seen in the last year on your Instagram, essentially you had dry needling, acupuncture. Just so I'm not paraphrasing, I'll do a direct quote. You said, this is not getting into the efficacy battle, but come on, let's be real. It's the same thing with a different theatrical story applied to it. If you watch a video of someone doing it on mute, and if it looks the same, it's pretty much the same. So I wonder if you want to respond to that. And even stepping out of needling, I mean, we put ourselves on mute in the clinic. You follow yourself around in the clinic and put yourself on mute. At first, you're a psychologist because you're just sitting there explaining pain. If you do any sort of soft tissue, now you're a massage therapist. If you do a manual-based manipulation, now you're a chiropractor. You go teach an exercise, you're a personal trainer. So just, do you think that type of rhetoric is just a slippery slope? And honestly, as someone in our profession, can you see how that can be misconstrued as damaging or almost arsenalizing people outside of our profession to say similar things?
Sure, I can see that. But I guess the thing that makes me comfortable with that is I don't define what we do or who we are by what we do, right? So if I'm on mute and I'm doing some soft tissue work and I look like a massage therapist, that's okay with me, because hey, massage therapists have value, and maybe they provide something to that particular patient at that particular time that is meaningful to them. And I'm not above saying that I'm the same as a massage therapist there. And if I'm prescribing exercise, hey, I'm a personal trainer. They have a lot of value too. And if I'm going to crack a neck, hey, I'm a chiropractor, because hey, maybe that has value and meaning to that patient in that particular scenario. So I don't define who I am or physical therapist by what we do. I define us by our education and our ability to mold clinically to the person in front of us and what they need at that time, while using a wide variety of evidence-based approaches in a framework that allows for, the whole funnel of evidence-based practice, your research, and then your clinical expertise. And then at the bottom of the funnel is patient preferences, and that you have to funnel that all the way down. And I think that all of those things kind of fall in there. And it doesn't bother me for somebody to think that I might be an acupuncturist if I'm on mute, if I'm doing dry needling. Just to circle back around to the original point there, I do think that it's just a difference in explanation, but it's the same. To me, sticking a needle is sticking a needle is sticking a needle. And you mentioned the intent. Now, intent is either to affect energy flows, your yin and your yang, and your chi, and over energy, under energy, or your approach is to affect a trigger point, or your approach is to affect a radiculopathic feedback loop, or your approach is to cause short-term muscle change through some neurophysiologic nondescript mechanism. To me, like, the sticking of the needle is the sticking of the needle, and all of the rhetoric that we put with it is just our own individualized way of trying to justify those treatments. So I don't think that what I said incorrect from what I believe, or different than what I believe, but I do think that it's probably worth more nuance and more discussion than an Instagram post can put forward. And I can certainly see how that would probably turn off some people, or seem pretty instigatory. And sometimes I do that to stimulate discussions. Sometimes I do that because I'm a normal human and I'm frustrated with something and I want to just put it out there. But I think that anytime somebody's willing to jump on a call and talk, we can have a really respectful, reasonable dialogue about what's going on there, and hopefully walk away with more understanding rather than more animosity.
Right. I agree with you there. And again, this is the exercise here, you and I chatting at each other on Zoom. And first of all, you kind of made the first point for me of one of the main reasons you can't make that on mute argument is that you are denying the education, the theoretical, and even the clinical context of an acupuncture treatment and a dry needling treatment. So you kind of made that for me of like, yeah, that was actually my main rub. Like, if we want to argue the technical aspects, the clinical aspects, and the mechanisms of acupuncture versus needling, that's one thing. But honestly, that's what was most frustrating to read that as a PT, as a colleague, is that when you make that on mute discussion, you're denying all of that education and everything else that goes into it. And I would challenge, I mean, we probably don't have the time today, that how we use a needle is different than acupuncture. I know there's over 100 different types of acupuncture. So some acupuncturists out there just disagreed with me. Just general feedback and minimal training that I have had in acupuncture, we use the needle different. Does that stimulate different responses? I would say so. You wouldn't. But even how we use the needle is different. And back to my initial point of really what makes the difference isn't the education, the training, the context before the needle. It's the change we're looking to stimulate, how we reinforce that in the entire practice model, the entire treatment model that makes physical therapy versus acupuncture. But yeah, I mean, that was one that got me, and I think I did jump in on that. To continue on a few more, not necessarily acupuncture versus dry needling specific, other direct quotes, you referred to dry needling as an elaborate theatrical placebo evoking a great meaning response, and you hate the fact it's surrounded by hype, exaggeration, over complexity, and downright batshit craziness. So explain those thoughts a little further and why you have such strong dissent, because those are strong words. That's not just saying I disagree with it. That's saying that's batshit crazy kind of stuff.
Well, I think that we've already alluded to that a little bit with the fact that every single dry needling institution teaches a different concept or theory. So if every single institution is teaching a different theory that ranges from energy flows to, semi-standardized acupoints to radiculopathic models to local neurophysiologic effects to cortical models to trigger points to actually breaking down adhesions is some of the stuff that I've been taught as well, physically releasing adhesions with the needle. If all of these different institutes have a different explanation, and they all argue with each other as well, then some of the stuff that does come out of that is a little bit crazy. It's a little bit outlandish. It's not supported claims at all. So that was probably strong language that I used. But the thing that frustrates me about it, and I think the reason that particular post that I was motivated to make those comments is because I had been given a string of referrals for patients where the physician who was referring to us demanded that we do dry needling no matter what on all of these patients. And it's because that physician had a friend in another state who is a physical therapist who said dry needling is the best thing since sliced bread. So now all of the patients that he sends absolutely has to have dry needling, and it's forcing people into a treatment approach that doesn't necessarily need it. It's forcing them. Some of those patients had excruciating pain, were very scared of needles, did not want that treatment, but were signing on for it because their surgeon made them, and they had that expectation. And then from a business perspective, you have the clinician on the other side saying, well, shit, I'm going to lose all of my referrals from these referral sources, and my financial well-being is going to be in jeopardy if I don't consent to doing a treatment that I don't necessarily think has a lot of value, and especially for this in particular person. And then the propagation of that concept through societal understandings is the final thing that I guess got me frustrated, is because when you apply a treatment or a concept over enough time, it becomes embedded into a social expectation. And then that social expectation actually fulfills the prophecy of needing that treatment. So it's just a cycle of, I have to do this treatment because society has told me I need this treatment. My colleagues have told me to do this treatment. I need this treatment to get better. So I'm going to go seeking that treatment. And even people that don't want to give me that treatment or don't think it's best for me are pigeonholed into having to consider it. So I know that is like a super long cascade. But I was in particular very frustrated that day because of what I perceived to be a little bit too much hype and a little bit too much excitement, especially to young and influential clinicians and to patients who may or may not have any concept of the science or the debate between this stuff. So yeah, it was an inflammatory post. And, like for yourself in particular, you've always been super kind and respectful to me. So I apologize if that was, upsetting to you or if it was disrespectful to you. But it was just, I guess, a little bit of a vent session about that stuff and about my feelings on the topic.
Well, I respect that, and thanks for that. And yeah, I luckily have thick skin, and luckily I've had this conversation enough that even today, it's not like either of us are sitting here trying to change each other's minds. It's just appreciating we're on different sides, different contexts, looking at kind of the same topic. And yeah, I totally. Honestly, if we want some truth here, one of the reasons dry needling has grown to what it is today is the business aspect of it. I even think you and Mark have alluded to it on your podcast of dry needling is one of those things that gets people in your doors. And not that, and I agree with you to say that if that is the main reason you're needling someone because it's a business venture or because they were referred to you specifically for dry needling, you might not have great outcomes. And if you're just doing needling for a business incentive, then yeah, I think we can all agree that that's not a reason why you use any type of treatment. And really your first comments, unfortunately, are not unique to needling, saying this group disagrees with this group underneath the dry needling umbrella. And that's honestly everything. I mean, if we put everything under the manual therapy umbrella that is manual therapy, from even the different articular joint-based methodologies to soft tissue to instrument assisted, those are all manual therapy. They're all going to say the other group is wrong, and this is what we're actually doing. And honestly, pain science is seeing a high tide right now. Pain science groups disagree with each other that we should be using interventions because we need to break the cycle, then we change the narrative. And then there's others that saying, we're not interventionalists. We need to learn our pain science so that we can communicate that to patients. So to be fair, that's not just the needle, that's everything in our profession. And that's how it should be, honestly. I mean, if we're ever a profession that says, this is the one thing we do and we all agree and there's no contention or challenge or like cynical, skeptical appraisal of what's happening, that's not a profession, that's not a medical profession, but that's not one I want to be a part of. So I agree with all that. And actually, same post to continue on and takes me to my next question. After the batshit craziness, you say, I'm constantly trying to re-educate, correct, battle against the ever-growing tidal wave of misinformation and bullshit around this treatment. So really that brings me to a question of, I understand your stance. And honestly, again, I think you have a unique voice because you've been trained in needling, you've done it before. So there's our audience is dry needling clinicians. What are your comments to a clinician, whether they've been doing it for a month or for years, and they have seen clinical benefit from needling? Is it your recommendation that they should focus less on this treatment and find other non-invasive, less invasive, less costly, less biased treatments for that patient?
So super good question. And, if you ask me this today, and if you ask me this a year from now, I may have a different answer. Yeah, I hope I have a different answer, honestly. My recommendation personally, and this is, the world according to Jared, so take it for what it's worth, it would be to just be reserved in what you think about any treatment approach. Because if history has taught us anything, it's that the treatment approaches that we learn and that we think are fantastic with time tend to show to not be quite as fantastic as we thought that they were. And really that's what's called the pessimistic meta-induction of facts, right? Is when we think that we have it figured out, that's exactly when we're wrong. And time shows us that we don't have it figured out. And that's, again, there's a million different things that have happened over the course of time that we thought were fantastic interventions that time has showed us just weren't, from trepanation to, drinking mercury to, lobotomies and all this sort of stuff, right? There's a million different things. So my recommendation would just be always hold a little bit of skepticism. You don't have to be as skeptical as me, but hold a little bit of skepticism, and not define yourself, not define how you interact with patients, not define your success by any one intervention, whether that's dry needling or education or exercise or anything like that, because that is a sure way to develop a backfire effect, to develop a sunken cost fallacy, thought process, to develop cognitive dissonance and just self-serving confirmation bias. When you go all in on any sort of treatment, it's difficult to step away and see things. So just always be a little bit skeptical and reserved. And I wouldn't tell people necessarily right now to just put down a needle and never stop needling again, never needle another patient again, because as I mentioned in the last little bit of dialogue that we had, is there's now a scenario in which there's a certain expectation from patients, from referral sources, from previous patients that you've needled, all this sort of stuff that sets up a really complex interplay of how you have to go about navigating that clinical encounter to allow for the best possible outcome. And it could be a situation where I don't want to use this phrase, but it's the only phrase I can think of. You choose the lesser of two evils because you're a really good, well-rounded clinician who's going to provide a lot of value through a multidisciplinary viewpoint and lens to a patient. If you meet their expectations of needling, and if you don't, they're going to be pissed off and leave, and they're going to go down the street to somebody that just lays them on a table for 60 minutes and doesn't work them towards valued activities in life, doesn't introduce any load to them. Like, you don't want to go down that route, but it's a very difficult, complex situation to navigate, because in my opinion, right, this is my opinion, I think that we've oversold needling just a little bit, and now it's going to be difficult to allow that pendulum to rest in the middle in some scenarios, because things like Kineticore have blown up, and what was Kineticore and James Dunning and all this sort of stuff. Because if you remember being a new grad, I do, you feel like you don't know anything. You feel like you're an idiot. You feel like you can't help patients get better. So you're looking for every quote unquote tool you can put in your tool belt. And needling is pretty sexy, and it makes you feel powerful. It makes you feel like a healer when you put that new little thing in your tool belt. So then you start doing it to everybody. And then you set up this scenario where you've influenced a lot of patients to expect that. And so I think that it's been overcooked just a little bit. And that's just, again, that's my personal opinion.
Right. And I'm on the other side of that, like I said, and I guess to use your words, I'd be in the camp that's overselling it, I guess. But honestly, I like to think, and again, my N of one, my personal N of one, is I was very skeptical. I took level one to hear the story and honestly to experience myself. And when I did start utilizing it early in my practice, despite everything we know now about setting up patient expectations and presenting it as like like you should set them up for success. This is something that I think will help you. I actually introduced needling into my practice quite the opposite. I straight up said, this is a brand new treatment. Like I'm newly trained in this. There's not a lot of research on it. So honestly, I want you, the patient, to be very honest with, is this helping? Is it not? I'm going to be overly diligent with my assessment. Like I'm going to test, retest constantly, because I honestly, right now, I'm in the phase of, does this help? Does this work or not? And I mean, again, it's my personal perspective on the other side of the fence that that's what's led me from that skeptical. Honestly, I was a very joint maintenance based. I went to Regis University, so Tim Flynn CPR. I went straight into NIOMT, which is all graded mobilization and manipulation. I was a very articular joint-based therapist introducing this myofascial, neuromyofascial treatment into my toolbox, like you said. And if anything, honestly, why I felt okay investing the money in those first few courses is, even if I decide not to use a needle on this patient, I'm looking at pain, dysfunction, and even the therapeutic mechanisms through a different lens, which is not joint-based input. It's not joint-based treatment. So that's where I started. And I like to think that there's probably other skeptics like you and I that are similar to me, that they entered it kind of skeptically. They invested their time and money. But why I feel on the business side, needling has taken off the way it has, aside from it being kind of the first invasive procedure of our profession, is that it helps patients. Patients request it, and that's not just a naive, it's not always a physician or an outside influence suggesting it. They want it because it helped them. And I know that that's kind of the argument that your side, the evidence-based side, doesn't like to hear, just the empirical. I do it because it helps, and that's the only reason I do it, kind of an explanation. But we have to realize that if this was the fad that was going to go away in a decade, it would have. I don't think needling is going to go away. I do think, even if we take away this argument of therapeutic mechanism and the research behind it, I do think that an invasive procedure of an otherwise very, very non-invasive, risk-adverse profession, it does signify a maturation of a doctoring profession. Invasive procedures have unique risks. We are a doctoring profession that can mitigate those risks with proper training, proper patient selection. I agree with you. You painted the picture earlier of, even though the physician highly recommended it, there are those patients that are cowering in the corner. They have a needle aversion. That's not going to be a patient you should needle. I mean, we know patient expectation, patient value on a treatment is highly important to outcomes. So obviously there's a middle ground. I hope you and I represent either end of the bell curve, but that means I hope that the majority of clinicians are somewhere in between that bell curve.
No,
Oh yeah, go ahead, comment.
I was just going to say definitely. And, we'll just, I think we'll both continue to patiently wait as really smart people, continue to teach us more about needling and about neurophysiology and about pain. And ideally, whether we're bickering about this stuff or not, and we have differences of opinions, ideally, we're just always moving towards being less wrong and always moving towards a middle point of what's the optimum, course of action for the patients that walk through our clinic. And in my personal viewpoint, shifting our mindset more towards a big public health type of initiative where physical therapists step into a role as, doctoral educated healthcare providers that do have a greater understanding of exercise, nutrition, public health style factors, sleep health, anxiety, et cetera, et cetera, et cetera, et cetera, and start helping people on more that level, primarily with the ability to intervene in specific, musculoskeletal complaints as well underneath that umbrella.
I agree. Honestly, to kick off the show, I had more stuff that you and I agree on. I just didn't want to seem too agreeable at the outset, but yeah, I mean, in a different conversation on a different podcast, 100% agree with you. The fitness forward, the load management, the load capacity, moving our patients and loading our patients, that fitness forward model is something we need to see more of. And I like that you had this conversation, but also in that context, you add the pain science behind all that. I believe with that holistic approach, and there is more that we agree on. I just didn't want to talk about it.
No, that wouldn't be good. That wouldn't be a good episode. There's got to be a little bit of,
I'm trying to sell tickets here. First of all, we're past the time. If you've watched the show before, we try and keep it to 15 minutes, but honestly, when you get someone like Jared on and we have to broach a topic like this, kind of threw the timer out the window. So I'll add one more. And again, it's kind of a chance for you to respond, because we've kind of heard the comments you've made, whatever, if it was a certain phase, certain scenario that led you to having a stronger voice or coming out with stronger dissent. But you have also made other stuff I agree with. You've written a blog called Expletive F Our Differences, basically saying that we do have different approaches. We have different methodologies as clinicians. You've said similar on your podcast with Mark, Modern Pain. So how do you balance, this kind of idea that you wrote about, that we all have different clinical beliefs, treatment approaches, differences of opinion, but ultimately that we should all kind of focus and unite on the similarity that is helping patients? How do you balance that with, again, some very strong language, and honestly, not just the singular posts, but when you go into the commentary with those posts? I mean, you have an audience, you have a large platform, and you lather up a lot of dissent against clinicians in your profession. You fractionalize, you stigmatize, not just needlers, but manual therapist, instrument assisted. So how do you balance this message that you promote over here as we should all focus on our similarities, and then you're almost actively mocking clinicians on the other? Like, how do you balance that, and how would you explain that to someone who has felt stigmatized by your commentary?
Oh, that's a great question, man. And in particular, in that blog that you're referencing, F Our Differences, my central premise for writing that was, we are bickering over, whether dry needling is acupuncture or acupuncture is dry needling. We're bickering over, whether the SI joint does or does not go out of place. We're bickering over the mechanisms of manual therapy. We're bickering over, do you pain neuroscience education somebody or do you not? And when you look at effect sizes globally across the research, they're really, really not that big. They're not that awesome for a lot of the interventions that we really gravitate towards and define ourselves by. And that's what I was alluding to before, that I think that we need to start looking bigger pictures. We need to F those differences, right? We need to get over those and recognize that a lot of the time, there are other factors at play that help people get better. Time being one of them, regression to the mean being another, natural history of a condition being another, short-term modulation over time being another, placebo effects and contextual effects being another. So there's all these things that over the course of a 6, 8, 10, 12 week, 1 year research study influence the outcomes. And then we're bickering over a 0.5 on the NPRS or a 1 out of 10 on the NPRS, NRPS or whatever it is, numeric pain rating scale. And I don't think that that's where we should be focusing anymore. And I did think that that's where we should be focusing. And my comment of, hey, forget our differences here. Let's not bicker over 0.5. Let's start focusing on the things that are going to reduce disability, that are going to reduce morbidity and mortality. Let's start getting people, at a healthier weight. Let's start helping promote public health education initiatives on nutrition and sleep and general activity guidelines and all of this sort of stuff. And then that should be a heavy focus of what we do. And then there are 30% or 40% or whatever percentage of patients who aren't going to get better over time. And we need to come up with highly specific, person-centered, N=1, approaches for those people. But we're over here bickering about 0.5 and 1.0 on 70% of people who are just going to get better over time. So again, I've apologized once on this podcast, and I'll apologize again to anybody that I've offended for, being divisive and that sort of stuff. And there was a time in my career when I wanted to be the next Adam Meekins, but why would you want to do that? The dude's already too good at what he does, and we don't need more of that. So I'll let him continue to carry that bastion, and I would rather be somebody that's more nuanced and more approachable. And I've been trying to shift my social media platform a little bit more that direction. And I know that there's occasionally still something inflammatory. But if you feel like you've been directly called out or ostracized or something by a comment that I've made, uh, I apologize that you felt that way. But if you did feel that way, that is also an opportunity to self-reflect. And I had mentors that were not they were not gentle with me. They did not hesitate to call out BS and improper thought processes, and it made me mad at first, and it made me upset, and it made me want to fight back. But now I'm like, crap, those guys were smart, and they were just trying to help me. So it's worth at least self-reflection. If you ever feel, quote unquote, triggered by something, you have to ask yourself why. Why do I feel that way? And I'm somebody that, social media, just anything that anybody says on social media doesn't upset me. And I know that that's probably not the way that everybody is. And I should recognize that and be a little bit more respectful that some people may be influenced or, feel a little bit more emotionally attacked by certain things that are said across the social media platform.
Yeah, and I am not just seeking an apology. That's not why I bring this up. And again, personally, doesn't bother me. I mean, a lot of my colleagues in the dry needling realm mute those conversations. I don't. I mean, like you said, you need to hear both sides. But yeah, I guess part of the question is, I'll just speak for me personally. I am over here helping my patients. I'm doing it in a way that has worked for me and that I substantiate. I know I have the biases, but a colleague with a very strong voice, and again, it's not just calling out you. You mentioned Adam Meekins, but there's people out there that have an enormous voice, a great platform, that seem to not always subscribe to your other message, which is, why are we talking about this? Because honestly, you're the one who brings it up. It's like, why are we talking about this 0.05% when we should be talking about the bigger picture? So that's why it comes up. And honestly, the few times I have jumped in and got frustrated, just like anything on social media, like I don't talk politics, I don't talk religion. It's like, as soon as you jump into those conversations, you immediately regret it, or at least I do. So I agree with that it's, I mean, you can't take it directly personally. But yeah, I think there are certain like figureheads in our profession that sometimes you just shake your head and like, it's like, why is that the message you're choosing to send out there? Because it's not bringing us together. It's kind of fractionalizing it. And that's just why I bring it up. And I honestly, I don't have time for all of the social media. I mean, maybe I am focusing on the 2% of your stuff and the other 98% is what we're talking about. So I also don't mean to just focus on the negative here, but this is a dry needling podcast, and I'm, those are the questions I had. But yeah, I think you've, again, not just looking for an apology, you've kind of painted the picture of what you're intending to do just with your platform, your experience, and your challenges. We are way past time. Is there anything you would like to wrap up with, or even like, is there one last message you would have? Let's just say that my audience is all dry needling clinicians. What's your final message to them?
Oh man, that's a difficult message to send. I think it's just kind of to echo what I said earlier is anytime you find yourself being enamored by any sort of treatment specific approach, it's just take a step back and really evaluate that. And if there are dissenters, if there are people aggressively against it, it's not a good idea to mute people. Banning people and muting people, that closes you off to the opportunity to learn something new. And you're probably not going to change your beliefs completely, but you might gradually update them over time. And that's what we're all trying to do. And I hope that I've verbalized that my views have changed over time, and I expect and hope that they will continue to change over time. And I also would just say, if there's ever a situation, I'm super receptive to private direct messages and jumping on phone calls with people and that sort of thing, just because I believe that real human communication typically works better than a comment board. And yeah, I think I would probably stop right there.
Yeah, and I agree with that. I mean, that's how you and I came to this place of mutual respect, and not everything is like you said, the feed commentary underneath a certain post. So I do appreciate that. And we are going to wrap up. First of all, if you don't already follow him, massive platform. He talks everything, like I mentioned, from his manual therapy, fellowship, OCS stuff with Optum to modern pain care. So you can find him on the modern pain care podcast from time to time. You can get his book, Making Sense of Pain or Wrinkles on the Inside, at Dr. Jared, Jarod Hall, DPT is both Instagram and Twitter if you don't already follow him. And I'm sure you'll hear his voice elsewhere. So thank you for your time today, man. I don't know if I occupied you longer than you were expecting, but I appreciate you sticking around for it all.
No, it's good. It's good. I do have a patient waiting. Got here about 5 minutes that I have to go see in about 5 minutes, but I enjoyed it and I didn't want to stop.
Awesome. Well, I really appreciate that. And you're off the hook because we're done. Next week, join us. We have another pain science guy, Adrian Lowe, fully admits that he is not the kind of clinician that you want needling you. He doesn't needle much, but I think he'll give dry needling maybe a rosier complexion or context in what he thinks it can do with pain science. And that's next week, same time. Thanks for joining this week. Jared, go see your patient. Thanks again, man. I'll see you on the social media and we'll catch you all next week.